third speaker for today, who is Dr. Sheetal Silal. And Sheetal is the director of the Modelling and Simulation Hub in Africa, known as MASHA, and also senior lecturer in the Department of Statistical Sciences at the University of Cape Town. She's an honorary visiting research fellow in tropical disease modelling at the Nuffield Department of Medicine at Oxford University, and she received a PhD in mathematical modelling of infectious diseases in 2014 from the University of Cape Town. Her primary research area is the development and application of mathematical models to malaria, pertussis, COVID-19 and other infectious diseases in South Africa and sub-Saharan Africa more broadly and globally, with a focus on using mathematical models to predict the dynamics and control of diseases, and in turn to evaluate the potential impact of control programs in reducing morbidity and mortality, and also with a focus on supporting policy development. And Sheetal is currently developing COVID-19 transmission models as part of the South African COVID-19 Modelling Consortium. And this consortium is a group of researchers from academic, non-profit and government institutions across South Africa. And the mandate of the group is to provide, assess and validate model projections to be used for planning purposes by the government of South Africa. Sheetal, over to you.
Thank you very much, Nim, and good afternoon, everyone. And thank you for having me on this presentation session today. So today I'm making a presentation on behalf of my colleagues and the modelling team working to support decision making in South Africa. And what I'd like to talk to you all about today is how we've had to adapt our models throughout the course of the epidemic with the aim of supporting decision making and remaining relevant to planning in South Africa. And perhaps more importantly than that, I'd like to talk about the importance of context and looking at the South African situation and the availability of data and contextualizing that with the outcomes of our models. So I do make this presentation on behalf of my colleagues. We come from three different modelling institutions. It's myself from the Modelling Simulation Hub Africa at University of Cape Town, Professor Juliet Pulliam from the South African DSI NRF Centre of Excellence in Epidemiological Modelling and Analysis, that's SACIMA at the University of Stellenbosch, and Dr. Gazina Meyer-Rath, Dr. Brooke Nichols, and Lisa Jameson from the Health Economics and Epidemiology Research Office at University of Witwatersrand. And we are three modelling groups who are working in conjunction with the NICD, and the representative and coordinator of our South African Modelling Consortium is Dr. Harry Moultrie. Now, to begin this presentation, perhaps we all know where South Africa is geographically, but in terms of COVID-19, South Africa is quite high up on the country listing when it comes to total confirmed cases. So currently, or as of 2 days ago, and still the case, South Africa is at position number 7 in the world for the number of positive confirmed cases, though considerably lower when it comes to the deaths per 1 million population. And as a group, the South African Modelling Consortium comprises academics and experts from both non-governmental and governmental institutions in the country. And the idea behind setting up such a consortium was to bring together expertise within or throughout the country. And our particular mandate as modelers was to develop modelling to support planning efforts. And so we developed both epidemiological and economic models among our three institutions. And the benefit of being part of a consortium like ours is that we received extensive and ongoing input from experts such as clinicians and virologists, intensivists, epidemiologists, public health experts, financial experts, economists, and so forth. And these experts allowed us to, or rather assisted us in refining our key model parameters and the assumptions underlying being the foundation of our models. So when our epidemic started in early March, we were faced with a situation where we had no local data, and yet we had to develop models for planning. And in the face of a lack of data, we opted for simpler models, generalized SEIR population level models with a simple pathway through hospital, separating just between the use of ICU and non-ICU beds. And the purpose behind developing the simple model was to provide a costing and assist with planning at a 6 month window. So here we are in March, just 3 months into the global epidemic, having to make projections for the next 6 months. And at this time, as modelers, we questioned, is it responsible to make projections over such a long period? Is there not such great uncertainty? We know so little, and we have no local context as to how the epidemic would play out in a country like South Africa. But we had to make these projections because planning had to happen much in advance of the peak of the epidemic. And so we had to planning such as, should we need field hospitals? What might the deficit in ICU beds be? Would we have sufficient ventilators? Or would we need to order them? Would we need to set up procurement contracts and order PPE, etc. in time in order to have a sufficient capacity when the need arose? And our solution at this time was to look at the epidemic in other countries and how it had progressed in other countries. So we looked at the northern experience and took age-related severity rates and applied them to the age structure of the South African population, knowing that we have a much younger population compared to many of the European countries. And we made our projections based primarily on global data. And at the start of May, we released a set of projections where we disaggregated our geographic space into the 9 provinces. That's one level below national. So the 9 provinces, centers of decision making as well, and looked to estimate the number of hospital beds that would be needed throughout the epidemic, and particularly the peak need, as well as cumulative deaths that might arise from this epidemic. And I'm not going to dwell too much on the projections themselves, because what was more important was, as modelers, how we had to communicate these projections and what was lacking when we made these projections. So as I mentioned, we had no local level data, so we had no idea on what the use or the requirements on or severity of infection would really be at a local level to determine the hospital pathway and the need for hospital services. At the same time, as a country, we had implemented a hard lockdown fairly early on, within the first month of our epidemic. And so it did not allow us much time to estimate an R0, for example, for our country. And again, we, as the previous speaker also mentioned, we needed to borrow R0s from the global experience. And likewise, at the time of us making our first set of long-term projections, we were still, or rather at the end of the first hard lockdown, which means we had no idea to estimate the impact of the lockdown. There was insufficient evidence to do so at the time. And so we brought to the forefront the one problem that we all know as modelers when it comes to disentangling the effects of different factors in our models, and that is non-identifiability. We were unable at the time to disentangle the impact of the intervention of the lockdown and base transmission as well as population behavior. When we made our set of our projections, we made projections not based on what anticipated use of services would be, but rather what the need for services might be, because we were assisting decision making for planning, and we planned rather on need compared to use. So with these projections, we anticipated that the actual utilization of services was likely to be lower. But another part of South African context that needed to be taken into account is that what might be classified as severe infection to allow entry into hospital and entry into ICU in northern countries may not be the same in South Africa, or in countries who have experienced COVID-19 prior to us would not necessarily be the same in South Africa. And so we had to contextualize that it is likely that with stricter thresholds for entry into hospital, our eventual use of services was likely to be quite a bit lower than the estimated need for services. With a virus like SARS-CoV-2 and our interventions being mainly non-pharmaceutical, the impact of behavioral change and population behavior in general, how a population behaves through social contact networks and heterogeneities in that behavior are of paramount importance to the epidemic. But again, in the absence of data, one does not have prior information as to the impact that the behavioral change and population behavior patterns would have on the future epidemic. So at this time, we had to make one further assumption that proved to be needing to be corrected quite soon after we released these projections. And that was, in the absence of any local level information, we assumed that the long run trajectory of the epidemic would be the same across different provinces in the country, adjusting for population size and adjusting for differences in age distribution. And you'll see shortly that we needed to update that particular assumption. Lastly, on the cost side, we had to design health budgets and project costs without really knowing in advance what the cost of ingredients were going to be and the number of resources required. So the one word that has, I think, been mentioned several times throughout the series of presentations this afternoon, and perhaps the most used word in all our communication with respect to our modeling throughout the epidemic, is uncertainty. There is just so much we don't know with respect to SARS-CoV-2 and COVID-19, both in terms of its underlying biology, but also in terms of population response to NPIs and their anticipated impact. And this differs for each country and within countries across the world. And yet our model projections have to be made. And in South Africa, our outputs were communicated and used by a number of departments for their planning. So perhaps to start with the obvious ones, we were assisting groups like facility readiness committees to determine the number of beds and the expansion of facilities required throughout the country. Our projections were used to assist with the planning of staffing levels required in order to service these beds and facilities, assisting with the procurement of ventilation, on drugs required, on oxygen, as well as designing testing algorithms or prioritizing of testing and determining the number of test kits to be bought. And so our results were continually being fed to or communicated to a number of partners at different levels of government throughout the country. So as I mentioned, as soon as we had released that first set of projections in May, it became quite apparent that the short-term experience between provinces in the country was very different. And we needed to take local level data into account, even though it may be incomplete and scanty. But we've got to start taking it into account if our models are to represent or have any semblance of what's going on in different areas in the country. And so we expanded our models. We expanded our models to take into account a more detailed pathway within hospital so that we could account for, or rather we could fit our models to hospital level data and hospital pathway data. And we decided next to release a series of short-term projections. We had done one 6-month projection, but in the short term, knowing how the virus could change and as our restrictions were being lifted into different levels, we decided to put through some short-term projections. And so we considered two kinds of short-term projections. One where we took into account the limited testing scenarios where we may not have enough testing kits to continue a mass testing strategy. So we looked at prioritized testing, and we also looked into the capacity that would be available in hospital and in general and ICU beds throughout the country. So what we have on the right-hand side is just an example plot to show the impact on of anticipated need in blue, but the impact of the currently available capacity and extended capacity once field hospitals, etc., would be in place for a particular area. And soon after that, it became apparent that in looking into, once again, contextualizing these findings to what we knew from data in the country, we would need to expand this analysis to all provinces in the country and take into account the available hospital beds throughout the country. We noticed also that there were differences in the hospital care pathways between the public and the private sector. And we knew that we had to make our model projections in the face of quite incomplete databases. And so we had to think carefully on what our model projections meant for the data that we did not have, given that it was not missing at random. And as soon as we had released these provincial projections and these provincial estimates on capacity throughout the country, it became evident once again that another update was in store for us. And in this particular update, it was required that for planning that a provincial level was not enough. We needed to disaggregate our findings even further to a lower level of district. To give you an idea, in South Africa, we have 9 provinces throughout the country, but 52 districts within the country. And so we had to allow our models to have a finer spatial granularity. And so version 3 of our model came to the fore. And as we moved into a finer granularity, we needed a finer set of data, a more granular set of data. And we had to get granular data on cases, but also connectivity between districts. And so we looked to mobile providers locally in the country, knowing that global providers like Facebook or Google Mobility were not necessarily representative sets of data for a country such as ours. So we looked to local mobile providers to assess the connectivity between districts. And this allowed us to project what we have in the bottom right-hand corner, estimates for each of the 52 districts in our country. And we were then met as modelers with the next conundrum, that we had so far been generating reports and presenting them to different departments in government. But with 52 districts and 52 sets of projections, that would make for a mighty long report. And so we had to very quickly develop an interactive dashboard of sorts in order to present our model results. And this proved to be quite useful in communicating our model results and allowing policymakers to view comparisons of results between districts and provinces in the country. So this allowed us to have maps where one could look at at adjacent districts and compare deaths and hospitalizations, cases, and so forth. With respect to our estimates, in our app, we showed both different sources of data as well as our model projections and allowed comparisons between different districts. And these results, our modeling results, were then able to be communicated effectively to the decision makers at different levels throughout the country. And after that particular update, we were still keeping track of what was going on and these differences in the trajectories of the epidemic throughout the country. And it was time for yet another update. And we were met with an interesting problem. The Western Cape, being one of the provinces, a province in South Africa with the first local epidemic, you could say, had an earlier than expected and lower than expected peak epidemic. And we were battling to understand why this might be the case. What could it be that could result in a peak of an epidemic being lower than projected and earlier than projected? And as a group of modelers, we set about considering different factors that could lead to such a pattern, an observed pattern in this case, mortality. And we considered aspects like a reduced susceptibility, so allowing for a certain proportion of the population to be considered immune. We looked at factors like behavioral change or behavioral response to mortality, where one has reduced interactions when the death rate is high. We looked at an overall better adherence to NPIs that perhaps counterintuitively would remain high even though restrictions were being lifted, as well as behavioral heterogeneity, looking at different contact patterns that would result in differential epidemic patterns. And what we concluded at the end of the day is that each one of these on their own could quite easily improve the fit of our model projections to the data in this particular province. And we had no local evidence yet for any one of these factors. And so the likely situation is that it is most probably a combination of all of these factors, though we have no local data for any one of them, or local evidence to suggest that any one of them might be the real reason why we have this particular observed pattern. And in yesterday's presentation, we also heard the concept of excess mortality. And this, I think, is one of the strengths of our response to the South African COVID-19 epidemic, is that we've had experts in different fields around the country all contributing simultaneously to analyzing different aspects of the epidemic. And this particular study was taken up by the South African Medical Research Council, where the idea was to estimate the number of excess deaths that had occurred during the epidemic in South Africa. Now, if we think about excess mortality, what we have to look at the difference between what is reported mortality and where that mortality comes from, and what excess mortality might where excess mortality might arise as well. So as modelers, we are considering that hospital pathway to generate fatalities, and these would be reported in hospital databases and in a public reporting system. However, there are also deaths that will go unreported. So for example, if a hospital doesn't report a death, then it would be unreported. Or if a person dies from COVID-19 before they get to a health facility, such deaths would not be attributed to COVID-19 and therefore unreported. And so we've had to we decided to incorporate this excess mortality analysis into our models. And we did so by estimating treatment-seeking behavior that would result in a proportion of the excess deaths being COVID-19. So in South Africa, the South African Medical Research Council analysis had estimated that between since the 6th of May until the 25th of August, excess deaths of 41,424. And if we take into account that presently in South Africa, so perhaps even a week ago, we had just under 15,000 deaths reported in the country. And so the analyses underway to compute the attribution or the proportion of cases of COVID-19 deaths among this total of 41,000 excess mortality. And we in our model are trying to take this into account as well. And so to end off, we are addressing the question of a second wave. This is perhaps one of the most asked questions at this time in the global epidemic. And in order to address it in South Africa, we're taking a number of factors into account. We're looking firstly at the international experience and the experience of other countries who have undergone resurgences, upswings, and second waves. We're looking at serology data as it becomes available in our country, though it may be perhaps for convenient samples at the moment, but looking to see how it can be used to inform our knowledge on the epidemic throughout the rest of the country. We're looking at the spatial distribution of cases as well as measures of social vulnerability throughout the country. The ideas on population density and the connection between social vulnerability and the epidemic as we know it. And using all of these factors, we hope in the next few weeks to be able to assess the future risk and timing of a second wave in South Africa. So to end off on just reflecting on a few lessons that we've learned throughout this epidemic, the first is that local data is not always available. And if it isn't, we need to make a plan as modelers, perhaps looking to borrow from the experience of other countries, but at the same time, remembering the context of one's own setting and communicating it effectively. Non-identifiability in disease models needs to always be highlighted and communicated effectively. And on that theme of communication, public communication of our modeling should be a full-time and ongoing effort. We have tried in our South African epidemic and perhaps not done it as well as we would have liked, but it's definitely a lesson that we've learned for the next time. And lastly, if we have to do adaptive, if we wish our models to be relevant, then we need to be adapting them continuously and in conjunction with the partners who are using them, because this allows for us to have a multidisciplinary modeling process and allows us to stay relevant. And I'd just like to end off by saying that as a disease modeler, someone who's worked in the field for a number of years, I've always worked perhaps with my own unit or with one or two other groups, and it has been an absolute pleasure and an inspiring and educational experience to work with multiple modeling groups towards this epidemic. And it's been an honor and a privilege to serve our country with our skill set during this epidemic. So thank you very much for your time.
Great, thank you so much, Sheetal. I really think you're to be congratulated in everything that you and the consortium have done to make these models so responsive and available to NDOH and other high-level decision makers. So let me follow up with a couple of interesting questions that come through from the audience. And the one is from Anonymous, but this is on the role of HIV. So South Africa, if I remember correctly, roughly perhaps around a 20% adult prevalence of HIV overall in the country. Could you tell us a bit about what is known about the role of HIV on SARS-CoV-2 infection, and indeed if there's anything, any role that is known in terms of shaping the amount of asymptomatic transmission, for example, versus symptomatic, and the extent to which you and colleagues in the consortium have tried to capture these dynamics in the models that you've developed?
Thanks. So at the moment we've had some data that has been released on the impact of HIV in particular areas within the country, and looking at increased risk in fatality and so forth. To date, we haven't yet incorporated that into our models because we are in the process of collating data and linking symptomatic data with fatality data. I think one of the lessons that we have learned in this epidemic is to be more prepared by linking our data systems. So linking the systems of different sources of fatality and where symptoms might be recorded. So that is underway.
Yeah, it's easy to forget we're still only months into this pandemic, isn't it? Yeah, so another anonymous question is also perhaps on a sort of more methodological basis. So you showed us very nicely how these models were graduating, if you like, from the simple models that you used in the absence of data to more and more complex models. And so the question is, when you increase the number of compartments in a model like this, does it increase the uncertainty in the predictions because there are more parameters to estimate? And at what point do you, or could you give the audience perhaps a sense of at what point as modelers you decide is the best balance between model complexity and simplicity?
Thanks. So that's a great question. As we have increased in complexity, yes, indeed, that increases the uncertainty with respect to parameters and also the issue of identifiability in our models. So our goal from the beginning was to increase the complexity of our models only as data became available to train the models. And that is also why we didn't, for example, go to a more granular level. We could have, for example, developed models at a ward level or a smaller area, but because we had no data in order to train your models at that level, we did not. So in the same light, we did not consider agent-based models Again, when it comes to population structure, there's very little evidence on behavioral and social contact networks. And what we have learned in South Africa is that there's heterogeneity in many aspects throughout the country, and is in terms of socioeconomic status and behavior and network structure and so forth. So to assume one population, a behavioral structure for the entire population would not be wise, and we would not be doing justice to the added complexity. So I think we have to look at a good lesson would be to always look at the data that you have before expanding your models.